talking about a relatively rare problem, but something that can be a significant problem in an individual's life. But from my perspective, easily treated and more easily treated when you catch it early versus when you put it off and try to manage it later on in life. And that is the diagnosis of what we call a carotid body tumor. And as you can see from the title of this talk, it's more than just a pain in the neck. These can actually be fairly problematic types of tumors. And the next slide goes into, basically, what do you have? And I want to answer the 4 questions. What do you have? What does it mean to have it? What can you do about it? And what are the risks associated with those choices? So the carotid body tumors that we're talking about are the paraganglion cells. They originate from cells in the carotid bifurcation, which you see here. You can all feel your carotid artery in your neck pulsating, and right about the level just above your thyroid is where the carotid artery bifurcates or branches into the external and the internal carotid artery. And in that region are some original cells called neural crest cells that play an important role in blood pressure regulation. And this is where these tumors can arise. Most of these tumors are benign, 90% of them. Less than 10% are malignant, and only 5% of them are bilateral. Now, I want to emphasize that this is part of a group of tumors that occur in your neck and up into your skull base. And so we're talking predominantly today about the carotid bifurcation types of tumors called carotid body tumors, or for that matter, they are called paraganglioma cells. Then there are tumors that can arise from the vagus nerve, and that's called a glomus tympanicum. Again, these all originate from the same types of cells. There are these original neural crest cells. They occur in different areas of the brain, and the glomus tympanicum occurs in the middle ear, and patients will present with tinnitus, ringing, or noises in their ear. Other individuals where your jugular vein starts at the base of your skull, you can get a glomus jugulare tumor. And the important aspects there are that the cranial nerves that innervate your tongue and swallowing, the 9th, 10th, and 11th cranial nerves are in that area, and they can be affected by tumors. And then there's the glomus intravagale, which is a tumor of the vagal nerve, and that is very difficultly treated surgically because it involves the vagus nerve. And then finally, there's the more aggressive type of tumor in the sense of the symptoms that it causes called a pheochromocytoma, which are these cells when they're in your adrenal gland or in your sympathetic chain. And these are more commonly secretory, which I refer to in the next slide. What does it mean to have it? Most of these tumors are very slow growing, meaning that they grow less than 2 centimeters over a 5-year period. However, they can be very problematic if they are secretory. And as I stated previously, the ones that are in your adrenal gland are more commonly secretory, and they can cause episodes of hypertension or cardiac arrhythmias, both of which can actually be fatal. And if the tumor is secretory, before you manage the lesion, either with radiation or with surgery, you want to know that so you know how to monitor and follow the patient with that disease process. The other thing to note is that there are families that have these paraganglion tumors, and if they are in a family, we more commonly look for bilateral disease, meaning that it's on both sides, in as high as 26% of the patient population. So how does a patient usually come to me? Most commonly, it's because they've got a lump in their neck. and it's causing a little bit of pain. It can be causing a little bit of voice hoarseness because it's affecting the vagus nerve. It can be causing difficulty with swallowing if the tumor is large enough and it's compressing the esophagus. For very, very large tumors that grow up towards the skull base, again, it can affect the vagus nerve significantly such that your vocal cords don't work properly, and patients can have either a very hoarse voice or a hollow sounding voice. If it affects the ninth cranial nerve, which is the glossal pharyngeal nerve, patients can complain about swallowing difficulties. And if it affects the 11th cranial nerve or the spinal accessory nerve, patients will have difficulty turning their head towards the side where the tumor is, or they'll have difficulty shrugging their shoulders. So how do we go about evaluating this type of tumor? The most common way and easiest way is to get an MRI scan with and without contrast, and it shows what the lesion looks like. Many patients will get a CT scan. It's not as effective, and the reason is that the MRI scan, you can also look at the blood vessels and you can try to differentiate the tumor from the blood vessels. And the most important aspect here, certainly when it comes to the carotid body tumors, is the tumor coming from the vagus nerve, because if it's a vagal nerve schwannoma, that is a very different disease than if it's this carotid body tumor. If you try to take out a vagal nerve schwannoma, you will give the patient a deficit in their vocal cord and their swallowing mechanism. So that has to be carefully evaluated before we would recommend surgery. And then finally, if we do believe that it's a paraganglioma, we often recommend what's called an angiogram, where we look at the blood vessels. These are very vascular tumors. And in my experience, I find it most effective to do something called embolization, where we put little particles in the blood vessels feeding the tumor, thereby reducing the blood loss during the resection of the tumor. What can we do about it? Next major question. Well, the treatment options are observation. If you finally notice a small little lump that's a centimeter and you're 85 years old and not having any symptoms, we're going to recommend observation. If you're 50 years old and you're having symptoms, you're going to live, we hope, for another 40 years, we would recommend intervention. For patients where we think that there's a close approximation to other important cranial nerves, we're going to recommend radiation treatment. But most commonly, we will recommend surgical excision, unless the tumor is so large that we think that surgery is going to leave you with more deficits than you already have. In that case, we would consider radiation as an attempt to try to control the rate of the tumor growth. So here's what we see when we evaluate you, all right? This is the top left image is an MRI image where we basically split you in what's called a sagittal view, where we go right down the middle of your head and neck and then open you like a book. And this is what you see. You see this white tumor mass. You see the carotid artery coming up here, and this is where it bifurcates or branches. And this is the angiogram that you see here, where the carotid artery comes up and it branches into the external carotid artery here. And the reason I know this is the external carotid artery is that it has branches going into your face. And then there's the internal carotid artery that continues up here and goes into your brain. Of the two, the internal carotid artery is more important. And you can see how vascular this lesion is. And most of the blood supply to this usually comes from a little blood vessel called the ascending pharyngeal artery that comes off right at the branch point of your carotid artery, which makes it very straightforward and easy for our endovascular surgeons to put a small little catheter into that artery, and then they dump something called polyvinyl alcohol, which goes into the blood vessels, and you can see what happens. All of a sudden, there's no blood supply to the tumor. So as you can imagine, what would you rather take out? Something that bleeds a lot or something that's relatively dry and makes it easy and straightforward to dissect this tumor off of the key structure here, which is called the internal and the common carotid artery. That is the one structure that we're trying to preserve. And then running just behind this blood vessel is the vagus nerve that runs within the sheath or the coating of the carotid artery. And we want to make sure that we don't injure that nerve as well, because as I said, the vagus nerve is responsible for swallowing. Excuse me, it's also responsible for control of your vocal cord. So it's important in terms of your ability to speak. So we make an oblique incision along the neck when we go about managing these surgically. And you can see here that here's the internal carotid or the common carotid artery coming up, internal and external branch points, and you see the tumor right here. And we go about dissecting this, and we have to meticulously dissect in the plane between the arteries and the tumor, and we resect it as a total mass, allowing us then to send it to pathology, and this has the normal pathologic picture of this type of cell. You can see that it's a homogeneous nucleus with a pink body, cell body around it. This was a non-secretory paraganglioma. We recently reported our experience with our last 22 patients, and the dialogue in that paper was about the merits of doing preoperative embolization or not. Many surgeons don't recommend it. I personally feel that the risks associated with embolization are so small that it is beneficial. It also minimizes the amount of manipulation and the amount of time that you have to spend getting control of blood loss and the amount of dissection that you have to perform off of both the carotid artery and the vagus nerve. And you can see here that the operating room times, when you compare our operating room times to what is reported in the literature without embolization, it was considerably shorter. So this is 173 minutes, which is a little bit over 3 hours. Now, that goes from the time the patient gets in the room, we put in a breathing tube, we do the operation, close it up, putting in arterial lines, IVs, and all the things, and then waking the patient up. So the operation itself takes about an hour and a half. And then we talk about the amount of blood loss. Again, you can see that in most cases, there was one patient that had some difficulty where the tumor had invaded the carotid artery, and we had to suture up the carotid artery. There was a considerable blood loss, but by and large, there's minimal blood loss of 50 mLs. This is a very safe procedure. The one patient that was in the hospital for 34 days wasn't nice enough to tell us that they had an issue with alcohol consumption, and so they had withdrawal and developed a pneumonia. 2 other patients had transient hoarseness, and as I explained, it's because we have to dissect these tumors off of the vagus nerve, and they can have temporary hoarseness. But that being said, removal of these lesions is safe. The average hospitalization, as you can see, is anywhere from 3 to 4 days. You wake up in the operating room, spend one night in the step-down unit. The next day we get you up to the bed. And the only reason you stick around for more than a day is that we have a drain in place just to make sure that you don't get any kind of swelling. Once that drain comes out, you can go home. So all in all, I would say that these are unusual tumors. They're common at our institution because we do a lot of them, but they're safely resected, and in the appropriate patient, we do recommend surgery. Again, I think that you want to be seen in an institution like ours at the Weill Cornell Brain and Spine Center, where we see a lot of patients. We have considerable experience in the resection of these, and we try to make the recommendations on the basis of how symptomatic you are, what the growth rate is, and what we think the surgical risks are based on the imaging and the angiogram studies. So with that, I will say thank you and open the floor to any potential questions. I see the first question I have from Jeremy is, do you really know if an arteriotomy will be needed prior to the surgery? The answer to that is no. Certainly, if the artery is encased by the tumor, then we know that we're not going to be able to get the entire tumor out. And in that scenario, we may actually talk about using radiation. And I would state that familial patients, your second question, did you mention that bilateral carotid body tumors are more likely to be familial? The answer to that, yes, is if you have a family history of carotid body tumors, it's more likely that they will be bilateral. So it's, however you want to express it, and that's about 26%. And then can you operate on bilateral carotid body tumors in one surgery? We would never do that, because if there was an injury to the vagus nerve, we wouldn't want to give you bilateral, both sides, paralysis of your vocal cords. That would be too much to handle in any one setting. So we want to make sure that we can get the tumor out. And then, a week later, we can certainly do the other side if the patient wants to do that. And the reason for maybe wanting to do that is then you only really have one surgical recovery. Tatiana or Roseanne, do we have any other questions? I don't see.
Nope. Someone's asking about if you would do a phone consult. Do you do telemedicine through North Carolina?
Yes, I do that all the time. I believe that at the end of this, my phone number, at the beginning, my phone number was there. You can call and you'll speak with Darcel, and you can make a phone appointment to speak with me. Happy to do that.
If you go on to the next slide.
I'm sorry, it helps if we do have the imaging before we have a conversation. So if we can get a disc sent up to us, it makes it easier.
Oh, my email I sent you, right? You got the email.
What is average recovery time return to work following CBT? Like I said, you leave the hospital in 3 days. Again, it depends upon the kind of work you do. If you're at a desk doing a lot of computer work, you can go back to work in a week. You've got an incision on your neck. It depends upon how important appearances are. If you're doing heavy labor, manual labor, I would want you to wait several weeks before you go back to work and let the wound heal up. The wound at the end is dressed with steri strips, and they come off as you start to shower, which is 2 to 3 days after surgery. Total wound healing time, so that we're comfortable with the wound, is about 2 weeks. And then for the incision to look more normal, it's about 6 weeks. So it really depends upon the kind of work that you do. If you're doing heavy manual labor, I would want you to wait, more in the 4 to 6 week range. If you're doing a computer desk job and it's not, or you can wear turtlenecks, you can go back to work the week after we do surgery. Any driving or light lifting restrictions after surgery? No. I mean, the neck is not that sore after surgery, so you can drive. Driving here in New York might be a little difficult if you have to change lanes and look around. And I see you were concerned about 2 of these tumors. Like I said, we can do the second tumor the week later, as long as we know that everything is fine. So that would be your call. And you know, in terms of follow-up, the goal is complete excision. You know, you follow up with me via distance. You know, we get an MRI scan at 3 months. If the tumor is not there, and we feel that we got a gross total excision, then we just follow you clinically. You know, once a year you check in and we have a phone call. So it's not a difficult follow-up regimen. Okay. Any other questions? Roseanne, Tatiana, anything else?
If you move on to the final slide.
I want to move on to the next slide that I see shows for people that do want to get in touch. Here you can see, you know, my office phone number, or how you can come to us at the Brain and Spine Center here at Weill Cornell.
I don't see any other questions right now.
Would you recommend to other surgeons to use intraoperative monitoring service to identify? When we operate, we do use EEG monitoring, just because if we have some bleeding in the carotid and we have to temporarily close it off, we want to know that the encephalogram is fine. We do use a handheld stimulator on occasion to make sure that the vagus nerve is intact, but we don't do, you know, you can do hypoglossal nerve monitoring, but we can usually identify that cranial nerve which controls the motion of your tongue grossly, and we can dissect that typically away from the tumor. So we don't use a lot of intraoperative monitoring.
Don't see any other questions.
All right. Well, thank you very much, everybody, for coming. It was a great pleasure, and hope this was informative. Don't hesitate to reach out if you have any further questions. I'm going to stop sharing, Roseanne. And
because that's what finance is going to use the P card, and the P card is a tax exempt card.